I understand there is a mutation that results in increased toxicity of aminoglycosides. What's the story here?
So this is a mitochondrial mutation, and it's normally associated or often associated with maternally transmitted deafness. So in this case, people who have got this mitochondrial mutation are much more likely to deafness induced by aminoglycosides, regardless of whether or not they have toxic levels of aminoglycosides. And when that's associated with a maternal history of deafness, then the risk goes up even further. So now there is also guidance that we should be testing people, and especially people who are likely to have repeated doses of aminoglycosides, to test them for this mitochondrial mutation, ideally before they're treated with aminoglycosides, but that's not often possible, especially when you need to treat acutely. But in some cases, for example, where we have individuals with cystic fibrosis who often have to have repeated courses, then at some point, as soon as possible, they should be treated. And certainly, if we have somebody with aminoglycoside-related toxicity, then recommendation is to test for this mutation, so that we can understand whether or not they've got that increased sensitivity to it. And the other thing is that neonates are also tested for this, and there is actually now a point of care test that is available to test neonates. So then that can be done before treatment started.
Interesting. Now, you mentioned a point of care test. Does that mean the test can be done there and then on the spot?
Yes. So this test is validated for the point of care test is validated for neonates. For the adult test, however, it's not immediate. It takes some time for the results to come back, which is why you can't normally test before you treat. And so at the moment, we are advocating initially to make sure that all people and patients who may need repeated treatment with aminoglycosides, so for example people with cystic fibrosis, etc., they're the ones who actually we're prioritizing at the moment, because they're at increased risk, and you can test, and even though you might have to have one treatment course before you get the results back, you'll know they're more likely to have more than one treatment course, so you could be more careful the next time.
So why can't the neonate test be used for adults?
All tests like this, they need to be validated to make sure that they are sensitive enough and specific enough for all of the different patient populations you want to use them in. And so this specific test has only currently been validated for neonates. If at any time, then the research shows that it's sensitive and specific and valid for adults, then I'm sure it will be made available for adults.
I see. Now, can I ask you about TPMT and NUDT15? Apparently known about for some time, but what's the problem here?
These are two enzymes which are part of the metabolic pathway for purine analogues. So, for example, thioguanine and other things. Now, again, these medicines are used in various different specialties. And actually, their role in the metabolic pathway, which again is if there's an enzyme deficiency, then people are more prone to increased toxicity. It has been known about for a long time, and in actual fact, although not the tests aren't commissioned by the NHS, they are actually part of the treatment pathway in those specialties. Now, the NHS has recently agreed to commission this testing for these drugs, but only in when these drugs are used for the treatment of acute lymphoblastic leukemia. And that's because before any test is commissioned, therefore paid for by the NHS, and there has to be a very rigorous assessment of the evidence and of the value for value for money, the cost effectiveness, and also clinicians have to request the inclusion of the test onto the test directory, which is sort of like the list of all the tests that the NHS will officially pay for. So the fact is that these tests, TPMT and NOD-T, are only officially commissioned, as in the NHS will officially pay for their use, when we're trying to treat people with ALL with purine analogues. However, they are still used in many other conditions where we treat with these drugs. So nobody's missing out, because we do still use them. It's been very long standing. It's just that actually they're only officially commissioned in the treatment of ALL.
That's very helpful. Would you like to comment on the relevance of pharmacogenomics to central nervous system drugs, CNS drugs?
The use of pharmacogenetic testing in mental health for psychotropic drugs is really interesting. There is no officially commissioned genetic test, but as a general rule, what we're looking for is whether or not somebody metabolizes particular drugs, either very slowly or very quickly. And there are particular genes that are involved in this. So what we're looking for is, for example, if somebody is an ultra rapid metabolizer, then they may well need a higher dose. And if they are a particularly slow metabolizer, then they might need a lower dose in order to not have side effects. So it's quite simple and straightforward in that it's very much just a genetic test to see whether or not you're a rapid metabolizer or a slow metabolizer, or whether you're a normal metabolizer. But the importance here is that even now, after decades and decades of having psychotropic drugs available to us, therapy is often still very much try it out and see. So if we had that advanced knowledge of whether or not somebody would be more responsive or less responsive, or more sensitive or less sensitive to this medication, then we'd actually, again, it's that coming back to that, being more precise in how we treat people. There is still a lot of work and a lot of research ongoing just to make sure that actually routinely testing people makes a difference to outcomes, because we can't assume that it absolutely will make a difference to outcomes. So that's the research that's ongoing at the moment. But it's very, very exciting, because it will be a huge advance in the way that in our therapeutic in our therapeutic models, if we know that we can test and then target the therapy to somebody's metabolic status, as it were.